Thank you so much for having me today to talk and try to spread some knowledge about myasthenia gravis. It's a privilege to be able to take care of patients with this condition. I've been doing it for almost 20 years now, so I guess that makes me seasoned, but I'm still learning. It's a humbling condition for us as neurologists because we're constantly learning from patients and patient experiences. And sometimes you may feel a little bit like a guinea pig as we try to figure out what's the best treatment for you. So I recognize that, those 30 to 60 minutes that you're in my office represent a very small fraction of your life with myasthenia gravis, and that you go home with that and have to live with that, and then I don't. So I understand it can be really challenging, especially at the start when a lot of people don't really understand where they're headed or what the disease is going to be like for them. So I'm going to go ahead and talk a little bit about it. I like talking about myasthenia because I've seen a lot of it. I don't know. I was trying to figure out the other night how many patients with this. I feel like I've seen probably close to 1,000 over 20 years. I don't have the numbers, but and everybody truly is different, and you really have to individualize treatment, and we get to know each other, and you probably get tired of my jokes and my anecdotes, and then but hopefully you leave and you're a little bit better off than when you started. So myasthenia gravis is an autoimmune disease. I think most people know that, and it's caused by the inability of the nerves to really pass the message along to the muscles. So how does that happen? It's a kind of a complex process. Our brain says, we want this muscle to contract, and then that message gets formulated in the front of our brains and then sent down through some pathways, and there's some other pathways that affect how that movement is coordinated, and all gets thrown together and sent down the spinal cord, and then exits the motor nerves, and then down and from the motor nerves to our muscles. And at that, this is all happening obviously very fast. And when the impulse gets from the nerve to the muscle, it has to send that message to the muscle, and it sends that message to the muscle by releasing a acetylcholine. It's a neurotransmitter which binds to a receptor on the muscle, and then in turn that message gets transmitted to the muscle through a very complex system of events, and then the muscle contracts. And we do that all day long without even thinking about it. So in myasthenia gravis, those receptors on the muscle are, they're blocked. Not all of them, and not all the muscles. So in some muscles, these receptors are being blocked by antibodies that our own body has made against them, and that impairs that transmission of that signal from the nerve to the muscle. And in a normal situation, again, so that acetylcholine goes across, it binds to the acetylcholine receptor, and then we can't continually contract our muscles. So something called acetylcholinesterase, and usually I make it like a little Pac-Man when I draw it out. The Pac-Man come in and they clean up the acetylcholine, and they recycle it back to the nerve terminal so this can continue. So this is how it happens. And then in myasthenia gravis, those antibodies are blocking the transmission of that signal, and it depends on what part of the muscle membrane is affected. But in about 85% of people with myasthenia gravis, it's the acetylcholine receptor. A much smaller percentage, there is an antibody against something called muscle-specific kinase, which we just call MuSK. And that's a very similar condition to acetylcholine receptor myasthenia gravis, with some slight differences. There are some other components of that muscle membrane, including the LRP4 component, which you see over there on the right. There are some patients that have antibodies against only LRP4, and then some also have antibodies against both the other ones as well. So that gets us up to somewhere in the mid-90s as far as percentage of patients that have antibodies. And now they've discovered some other antibodies, these agrin-associated antibodies, that about 7 to 8% of patients will have, and about half the patients that are seronegative for those other antibodies. So we're really getting up there. People that are much smarter than me are figuring this stuff out. And then, hopefully we don't have to tell people they're seronegative for myasthenia gravis anymore, because that's a very difficult spot to be in, to be seronegative with myasthenia gravis. It sometimes leaves doubt in the treating neurologist's mind. Is this really myasthenia, especially if it's kind of a weird presentation or something. So that's generally the antibody distribution for people with myasthenia gravis. So, a little bit of history. This might be boring. I don't know. Some of it's interesting. And it was originally described in 1672. Obviously, people had myasthenia gravis before that, but in the medical literature, it was described. This person, Thomas Willis, said, in the morning, these patients in the morning are able to walk firmly, to fling about their arms hither and thither, or to take up any heavy lifting before noon. The stock spirits being spent, which had flowed in the muscles, they are scarce able to move hand or foot. These people wrote really long notes. So basically, people got weak as the day went on. So, they had a lot of time on their hands to be more descriptive. So the first modern description was by Samuel Wilkes in 1877. And then others started kind of getting on board. And I don't read German or speak it. But I imagine that has something to do with being weak in the muscles, the swallowing muscles and the extremities. So I do know how to ask for double room in Germany, in German. Yes, so that's about it. In 1895, myasthenia gravis was coined by Jolly, and he called it myasthenia gravis pseudoparalytica. And, so this disease was really confusing to people back then because, as this is a very wide presentation of clinically, but, some people were dying from this condition. A lot of people were dying from this condition. And it looked very much like ALS in that they lost their ability to chew and swallow, and their breathing was affected. So while they were kind of starting to learn about ALS, these folks, after they, post-mortem, they would look at their spinal cords and brain stems, and they looked totally normal. Whereas in ALS, all these things were quite atrophied from all the loss of cells that control the muscles. So they were really perplexed. And, it was much later when they discovered that these are actually caused by antibodies. One thing that they also discovered when they'd see these folks post-mortem was that some of them had tumors of their thymus gland, which I'll talk about a little bit in a minute. But so they thought it was strange. These people, certain percentage of these people have this thymoma, or this enlarged thymus gland. And that, that's a gland that, tends to go away after our early development. So they wondered about that and how that could be related to this, different disease. And then, as they got better at kind of identifying myasthenia gravis, they started sending people to, they started wondering if you could take these thymomas out, if they would possibly get better. But in Germany, they really weren't very good at taking out thymus glands. Open chest surgery was not very successful back then because we didn't have the same type of treatments available and availability of antibiotics. So it was, if you had your chest opened up, it was not an ideal situation. But amazingly, the Swiss did because they were a landlocked country and they didn't have much iodine in their diet. So they had some experience treating goiter, which is a condition of the thyroid. And so that's kind of a little bit above the thymus gland, but so these folks were comfortable operating that area. So they would basically refer people to Switzerland for for thymectomies. So that's sort of interesting. And then they started doing more of these thymectomies in the early 1900s, and eventually at like places like Hopkins, and then that became a treatment for patients with myasthenia. And then not too long after that, Mary Walker was a physician in England who, the story is a little bit depending on what you read, but she was in the wards with her patients with myasthenia when a visiting neurologist from the United States, Dr. Derek Denny Brown, was visiting, and he remarked that these patients looked similar to those afflicted with curare poisoning. And curare is a poison that people use to hunt, and it paralyzes the prey by interacting with the same mechanisms that I described earlier about the nerves talking to the muscles. So this kind of set off a light bulb in her head. So she started trying to treat these patients with something called physostigmine, which is an early cousin of pyridostigmine, which you all know as Mestinon. And so these are the first people that were treated medically for myasthenia gravis with medication. And then eventually, corticosteroids came around in the 1950s and 60s, and then 70s and 80s, plasma exchange. Then IVIG came along, and now we're way out there. We got a lot of different medications available to us now. So can we drop the gravis? Gravis means serious or grave. That sounds bad. It sounds like if I have something grave, that means I could die. And well, that doesn't really happen anymore, but it's still, in a very small percentage of people, can be very serious. As early as or recent as the 50s and 60s, mortality was 70 to 80% with this disease. And now, as with having these treatments available, that's dropped considerably. And patients can succumb to the disease in the midst of a crisis, but typically those folks are very sick with other conditions. They're in the hospital. They may have infections. They may be, post-surgery. So these folks usually are really sick, or towards the end of their lives. So it's very unusual for people to die from myasthenia gravis. They looked at, in Denmark, they looked at, is there any characteristics that were unique about these? These patients did have a higher mortality rate than the general population, and that mortality rate was most pronounced during the first 5 years of their diagnosis, and it was worse in late onset women. So about 1 to 2 per 100,000 get this disease per year. So 10 to 20 per 100,000 in the U.S., and that is increasing probably because we're getting better at diagnosing it. It's so roughly about 36 to 60,000 cases in the U.S. And it's basically broken up into 3 different presentations. You have early onset, the 2nd through the 5th decade, which is a female predominance and is typically involves some enlargement of the thymus gland. And then the intermediate onset which is the 4th through 7th decade, and those have predominantly have thymomas present. And then late onset, which I feel like is what I see mostly, 6th to 9th decade, male predominance. I don't know if I agree with that, but and thymus abnormalities are typically absent. So when people present with this condition, it can be a variety of ways, and it's probably most easy to diagnose when people present with ocular myasthenia, in which the eye muscles are mostly affected, and people get double vision because the eyes can't move together in sync. And so you have 2 images that are going on the retina, and the brain gets confused and it sees it as 2 images. So about 50 to 70% of people present with just ocular myasthenia, and of those, as high as 83% can secondarily generalize, which means they can develop weakness in other parts of their body. Some people present with generalized weakness, about 35%, and 15 to 20% of them will present with what we call bulbar weakness, which is weakness of the swallowing muscles, the tongue, and then some 10 to 15% with just appendicular, which is just weakness of the extremities. Some people just present with fatigue, and that can be really tricky because fatigue is, everybody's fatigued. Everybody's working hard, and everybody has fatigue as you get older. You don't know, is like this just a normal process of aging, or what is it? But so some people get fatigue. Respiratory people, some present with respiratory failure, and that's typically in the hospital in the setting of other conditions. So they have some other stressor that has got them in the hospital, and then they may be intubated for something on a ventilator, and they can't get them off the ventilator. And then they find out that they have myasthenia gravis. There are very unusual presentations. I've had patients present with foot drop on one limb or finger drop on one limb. That's very odd, and so you have to really dig deep and try to come up with myasthenia gravis as a possible explanation for this when there are so many other causes. Patients tend to get weak later in the day. They feel best in the morning, but that's not always the case. Some people feel the worst when they get up in the morning, and they get better as the day goes on. So it's a little tricky, but most people will describe this feeling of getting worse as the day goes on. We do have to think about other conditions when we're considering myasthenia gravis as a diagnosis. Oftentimes ALS is one that is confused, just because ALS also can affect the swallowing muscles and the tongue muscle. ALS doesn't tend to involve the ocular muscles at all. So if somebody has double vision, that usually points away from ALS. But sometimes people have lazy eye, and then they also have ALS, so it can look like myasthenia gravis. There's Lambert-Eaton myasthenic syndrome, Kennedy syndrome. There's a lot of conditions here that mostly things that present with fatigable weakness or problems chewing or swallowing. Those are the things that could get confused for myasthenia gravis. And just as an aside, some patients can have more than one thing, and I already have a few patients that have an inflammatory myopathy and myasthenia gravis. So that's really challenging because you're trying to figure out what's causing what. So there's some treatment overlap for both of those conditions, but it can be really challenging. So when we see somebody that comes in the office with these complaints of double vision and problems chewing, swallowing, weakness, fatigue, maybe head drop, they're having trouble holding their head up. They say, when I'm carrying the laundry up the stairs, I can't hold myself up. I can't hold the laundry basket up. I can only walk so far before I have to sit down. These kinds of things. We examine folks, and then we do some diagnostic testing to confirm our suspicions. And part of that involves checking for some of those antibodies, which I described earlier. Of the acetylcholine receptor antibodies, which I described, there are a couple of subtypes. There's modulating and blocking. I don't typically order those, but some people order them. I'm not even sure if they're on the Mayo panel anymore, but and partly because of their utility, we don't really know how useful they are. Modulating antibodies, titers or elevations might have something to do with the severity of the disease, while blocking antibodies might be useful for patients that have purely ocular myasthenia. In some instances, we may check a paraneoplastic panel, which is basically a panel of antibodies for conditions that have that are associated with certain types of cancers, and that the acetylcholine receptor antibody is on that panel, along with the voltage-gated calcium channel antibodies, which is associated with something they call Lambert-Eaton myasthenic syndrome. There are some availability labs that will perform the LRP4 testing. So for patients where we test acetylcholine and MuSK antibodies are negative, we still think they might have myasthenia. We can check for LRP4, and I imagine agrin-associated antibody testing is available probably more for academic purposes or research studies. And then striational antibodies can be found in some patients with myasthenia gravis, and they are not diagnostic of myasthenia gravis, but they can have some association with the presence of an underlying thymoma and may predict severity of the disease. And that's another one where the utility of that is a little in question, because most of the time when people get diagnosed with myasthenia, we're going to get a chest CT to look for a thymoma. So I have used it in patients where they weren't getting better, and maybe the initial CT was negative, and maybe they had a little extra thymus tissue. I might order that just to see if it's really elevated, maybe to push for thymectomy in those patients. We also check thyroid lab testing, because that can affect the eye muscles as well as cause, thyroid disease can cause fatigue. Vitamin D, there's a little bit of association with low vitamin D and autoimmune disorders. And I like to just check, general labs, blood counts and kidney function and electrolytes, just to see in general how people are doing. If you can certainly be fatigued from being anemic. So yeah, we do get we will get, once we're convinced somebody has myasthenia, we'll get a CT of the chest, and that thymus gland sits right in front of the heart, and that those green arrows are pointing to a thymoma, which is a benign tumor of the thymus gland. We don't do it a whole lot these days because we're so good at diagnosing this with just lab testing, but some folks that we think may have seronegative myasthenia gravis, we will take into the EMG lab, and we'll do electrodiagnostic testing, which some of you may have had, and that involves stimulating the nerves repeatedly to look for a decrement in the response as caused by this effect of the antibodies on the receptors on the muscle. And an even more specialized test called a single fiber EMG is used in even rarer situations. So most of the single fiber EMGs we do are normal, because most people are already diagnosed with myasthenia by other means. That picture down on the bottom right is just an example of what we call jitter in myasthenia gravis on single fiber EMG. Now, I've never seen a tensilon test, but maybe some of you are old enough to have had one or have seen one. A tensilon test, it's kind of like a super high dose mestinon, where somebody comes in, they think they have this condition. We give this medication to see if their symptoms get better, and then that's supposedly diagnostic. The problem is it's kind of an easily manipulable test. So, I give you a medication, you say, oh, I don't see double anymore. So it's a little tricky. And then the drug can cause, the heart to stop. So, you don't want to do that. I don't know. I don't know if anybody's still doing tensilon tests, but I've never seen one done. We might check pulmonary function testing to get an idea. Some people present with a lot of shortness of breath, yet they don't have any of the other symptoms, and that's a little unusual. Or maybe they have myasthenia gravis, and then they start getting more short of breath while the other symptoms don't get worse. So that's a little bit of a disconnect. So we might get pulmonary function testing just to tease out, maybe it's caused from something else like COPD or asthma, or some other intrinsic lung problem. So that can be very useful. we may do the same thing for swallowing and speech if it just doesn't seem to fit with myasthenia gravis. People have trouble swallowing. Things get caught up in the in the back of their throat. They can't really manipulate the food. Their tongue is weak. They can't get the food to the back of their mouth. But some people describe more of a sensation where the food gets stuck in their, further down the esophagus or even in their chest. And that, would be really unusual for myasthenia gravis. So you have to really ask those questions. When somebody says, yeah, I'm having trouble swallowing, they don't know the difference. You're not doctors, so you have to ask questions to try to sort that out. There are, rheumatologic conditions that can cause slowing of the motility of the esophagus. Some people get, narrowing of their esophagus for whatever reason. So, we have to ask those questions and sort it out, and not try to blame everything on myasthenia gravis. So the treatment has come a long way, as I described earlier. So pyridostigmine is Mestinon, and some people call it Mastodon. That's a prehistoric elephant. But Mestinon is the actual name of the medication. There is a long-acting form, which we use very rarely, but this is a medication that does not treat myasthenia gravis. Well, what do you mean it doesn't treat myasthenia? Well, it doesn't do anything to the disease. But remember, I was telling you about those Pac-Men earlier that come in and clean up the acetylcholine in the neuromuscular junction. Well, the pyridostigmine blocks those Pac-Men from working, so it leaves the acetylcholine in the neuromuscular junction longer to compete with those antibodies to help the muscles contract. It makes people feel better for that reason. So we call them, speaking of Pac-Man, when he has power pellets and he gets power pellets to eat ghosts. So I call them like power pellets. So that's a pyridostigmine, although blocks the Pac-Man. So I don't know, maybe that's not a good analogy. So anyway, the Mestinon will make you feel stronger. It might make your eyes work better. It might make your speech a little stronger, but it's not actually treating the disease. And it's actually a disease tested for in Olympians because it's as a drug, a performance-enhancing drug. And a lot of people, when they take it, they will feel better on it, just in general. That is, if they can handle the muscle cramps, the stomach pain, the diarrhea, the flatulence, the runny eyes, runny nose, and come along with it. So it sounds like a lovely drug, but not everybody gets those side effects. And some people can take a lot, and some people get very ill right after taking it. So oftentimes early in the disease, we might put somebody on this medication to help, while we're waiting for some of this test to come back, and just to see if you're getting better. And it's a drug that you don't have to take 3 times a day or 4 times a day. You can take it as needed. You can take it during those times of the day when you really need it, or you can take it if you're planning something where you're gonna, you might start to get fatigued or tired or weak, or you don't want it, you're gonna be talking a lot. You can take it as needed, almost like you take a Motrin for pain. So you don't have to take it as scheduled. And certainly if you're taking a lot of it, we're probably not treating you the best we can. So I liken it to like the icing on the cake. The cake is made with immune suppression, which I'm going to talk about, and then the icing is the Mestinon. And sometimes we get away with just treating people with Mestinon, and that's great because then you don't have to deal with all this other business. And what is the other business? Well, steroids are a great drug for putting myasthenia in its place, and it works by suppressing the immune system sort of globally. And you need to do it at a fairly high dose for a pretty long period of time, 2 to 3 months at a high dose, and in order to really see the effect. But steroids, as one of my patients described it, as the devil's tic tac. It comes with a lot of side effects. It affects every organ system in our body, from the eyes. It can cause cataracts and glaucoma. It causes hair loss, and hair in weird places. It causes weight gain. salt and water retention, high blood sugars, high blood pressure, skin changes, bruising, osteoporosis, you name it. It's a devastating drug, but it does work. So that is still the primary mainstay, I would say, of early treatment of myasthenia gravis. But the idea is to get in and get out. So get the disease under control and then taper it off. And we taper it off with some of these other medications to take its place. These so-called steroid-sparing agents, azathioprine, which is Imuran, and mycophenolate, which is Cellcept. They block rapidly proliferating B and T cells, which are making those antibodies against the disease or against the receptors. So by themselves, there's no evidence that either of those drugs work for treating the disease. You will hear people say that they were only treated with one of these and their disease got better. Now, was that going to happen anyway? About 10% of myasthenia gravis will go into remission on its own. So, some of these medications will, we think that they're doing something and probably they're not doing anything at all, but we're going to take credit for it, right? So my former chair used to say, hurry up and do something before the patient gets better. We don't know if these are the things that are working, but we don't want to sit around and wait and see either, right? So we use those drugs to try to get people off of steroids. The other drugs listed there, IVIG is intravenous immunoglobulins, which is made from the plasma of donors with these IG immunoglobulins, which basically, it's a complicated mechanism of action, but basically neutralize the antibodies that are causing myasthenia gravis. The infusion is typically given over 2 to 5 days at the beginning, and then maybe monthly or afterwards. It can take a few hours. It's pretty well tolerated. It works really fast, so it's nice in people that are getting weak sort of more quickly. But it's expensive, and insurance companies aren't really super interested in paying for it as a long-term treatment for the disease. One advantage is it can be given through a regular, IV. Plasma exchange is a method in which we take the plasma off the person through a machine, run it through, and then we replace that the plasma with albumin, and that pulls off those antibodies from patients, and that can last, just like IVIG can last about a month or longer. It buys us time where we're trying to figure out how we're going to treat this disease in the long term. Most people can have this done through peripheral IVs, but some people we need to put in a more central venous catheter in order to because there's such a large volume of fluids being taken from the body and put back in. So it's very effective. As I've gotten older and more seasoned, I guess, as a neurologist, I've leaned on plasma exchange as a temporary measure for people who, they don't really want to go on steroids. They don't want to go on immunosuppressants. Their disease is fairly controlled, but every few months it tends to kind of get a little worse, or their symptoms get worse. So we do intermittent plasma exchange, and it works really well. It's just a nice thing to have in your back pocket. Thymectomy is another treatment for patients that are typically younger. Now, whenever somebody has a thymoma, that thymoma has to come out. That if they have a thymoma, that's a tumor. It's going to keep growing, regardless of its effect on myasthenia gravis. We have to get rid of it. Some thymomas are not benign, and they can spread out to other parts of the body. So-called metastatic thymoma, a very difficult to treat condition. But so we in some patients, they just have extra thymus tissue. So we might want to take that thymus tissue out. And there, was a long 6-year study that was done that proved that was the case, that it does work. and it does reduce the need for medication. I think I have a slide later on that. But the thymus gland is a tricky gland. It's not like a kidney or a spleen or a liver. It's not sitting right out there like a normal organ, and in fact can be kind of spread around the chest in little islands. And this picture over here shows that, so you don't just, you go in and you just, well, there's the thymus gland, take it out, but you can have parts of the thymus deep embedded as little islands in the fat around the heart, around the thyroid, and all this. So, neurologists used to get upset, say, well, the only way to get a thymus gland out is by actually opening up the sternum and visualizing it and taking it out, but the, thoracic surgeons are very good these days using robotics, and they can go through laparoscopic means and they just suck all that fat out of there and they get it out, and they say they get everything, but I don't really know if they get everything, because I've had patients that had recurrent thymoma, even though they had this done laparoscopically. So it's a little tricky, but it's also not fun to have an open sternotomy where you open your chest up. It's very painful, and it's hard to breathe afterwards, and it's just a very uncomfortable condition to have, or surgery to have. So I want to talk about some of the newer therapies that have come around, and these drugs are great, and my experience so far with them has been pretty good. And I have a favorite, but I'm not going to tell you which one it is. But that's a picture of the new kids on the block. I don't know if any of you remember who they are, but this Wahlberg here, their family, they own a hamburger place too. But so the new drugs are broken up into basically two different groups: the complement inhibitors, and then the FC receptor inhibitors. So I have a little picture of that, but the complement inhibitors are eculizumab. It's an IV drug that's given every 2 weeks, and in order to get this drug, you need a meningitis vaccine. Ravulizumab is a little bit newer, and that's given every 2 months, and that also requires a meningitis vaccine. We were part of a clinical trial for ravulizumab that helped get it approved, so I had a little bit of experience with it before it was approved. Of the FC receptor inhibitors, efgartigimod is the first one that came out, and that's an IV drug that's given weekly ×4. Then, depending on the response, maybe every 50 or more days. There's no vaccine required there. There's a newer version of this that's given subcutaneously, and that means it's given under the skin. And that is also weekly ×4 with a similar, depending on response, you can start another cycle. No vaccine is required. And then the newest one, I believe, this is a hard one to say, rosanolixizumab is also a subcutaneous FC inhibitor, and that's given weekly for 6 weeks. Then, depending on the response, 60 up to 63 days later, and no vaccine is required. So real quick, so thinking of the drugs we use, so prednisone kind of suppresses all of these B cells, T cells, the CellCept and the mycophenolate and the azathioprine, they suppress B cells and T cells that are produced, so that lowers the antibody production. The complement inhibitors, well, complement is something that's involved in this immune response. The antibody binds the receptor and it sends off signals to something called complement. Complement comes over, sets up shop, and it helps kind of get rid of the receptor that on the muscle, because the body thinks this thing is foreign, so it's there to get rid of it and digest it. So the complement inhibitors prevent that from happening, and it helps the neuromuscular junction stay intact and that those receptors stay intact. And that's a huge deal in somebody who's getting worse in myasthenia. because as the disease gets worse, these receptors, they're getting digested and sent off, and the neuromuscular junction is starting to look like a war zone. And so the complement inhibitors kind of prevent that from happening, or prevent it from going on, so that the neuromuscular junction can repair itself. And then the FCR antagonists, so the FC receptor is actually involved in recycling antibodies. So if you have something that's foreign that's attacking you, and your body attacks it and wants to get rid of it, well, it's kind of good to keep those antibodies around. So the FC receptor helps recycle those antibodies, and so but we don't want that in myasthenia gravis. So the FC receptor antagonists block that and prevent those receptors or those antibodies from being recycled, and then that lowers the effect of the disease. So here's a little cartoon of that complement inhibition I was telling you about. So the nerve sends a message across the membrane, and antibodies are blocking this. So this complement comes in, sets up shop, and is trying to get rid of all this, and then in the process gets rid of the receptors, and the muscle membrane gets kind of changed. So the complement inhibitors block this from happening. It's pretty cool. Somebody thought of that. And then here's a cartoon for the FC receptor. Typically the antibody and whatever it's attached to gets ingested into the cell, and the FC receptor comes in and saves the antibody, and everything else gets degraded. And then the antibody gets spit back out to do its duty again. But in the inhibition of this FC receptor, that it's blocked, and then that doesn't happen, and then the antibodies get degraded. So in myasthenia, that's what we would like that to happen. And these drugs, while doing that, do not drastically affect the immune system to the point that you are unable to fight off infections. However, in the complement inhibitors, I mentioned before, you do have to get a meningitis vaccine, because it can have an effect on that, your ability to fight off meningitis, and that could be, deadly. So that's why we give the meningitis vaccine. So here's the catch. Prednisone is really cheap. You can get prednisone cheap. You can even get, Celsep and Imuran fairly cheap compared to these. Eculizumab can be as high as $700,000 a year. It's, every 2 weeks you're getting an infusion. There's infusion costs associated with that, drug costs associated with that. Hell, there may even be travel costs, for you. You don't live near an infusion center, so it gets to be pretty expensive. Insurance companies will cover these drugs and the infusion costs, but some people don't have, coverage that covers all that, or there's a copay, and that really can take a bite out of your, of the money you have to live on, especially these days when everything's so expensive. And there are, each company has their own way of kind of helping to reduce that cost so that you can get the therapy. But, that takes a lot of work on both ends, and it can be really challenging. Ravulizumab seems like an easier, cheaper choice than eculizumab, with a little less money per year, and you're getting it, every 2 months. So it's a little, you're not going to the infusion center every 2 weeks. So that seems like a better option. But in my experience thus far, I've had trouble switching people from eculizumab to ravulizumab, because the logic of the insurance companies is limited. They think that if you want to switch, then you should have to fail efgartigimod in order to go to ravulizumab, which makes no sense at all. We're just trying to make it easier for the patient, actually cheaper for the insurance company. Yeah, it's frustrating. So anyway, efgartigimod, a little bit cheaper, and maybe less too, because if you're responding really well to it, you might not get the infusion as often. Same with the subcutaneous version and this other newer version. They're all, that's a lot of money being spent there. And I would say In some patients, definitely worth it. And in others, I think we can get the disease under control with other means, cheaper means. But, sometimes people just, they can't go on steroids for certain reasons, or they can't, they didn't tolerate mycophenolate, or they can't get IVIG, or, whatever it is. There are certain reasons you have to switch to one of these drugs. And they do work, and some people, they work incredibly well. So fourth line drugs, rituximab is, before these other drugs came out, we were starting to use rituximab a little bit more for people who had myasthenia that was not under control. It does work very well for myasthenia. There is evidence that it works in all forms of myasthenia. So we will occasionally use it for acetylcholine receptor myasthenia gravis. Cyclosporin, cyclophosphamide, tacrolimus. These are drugs that probably work in myasthenia to some degree, but given that we have so many other options now, I doubt anybody's really using them. Going back to the thymectomy study, these folks all had transsternal, so they had an open sternotomy, and that showed they had a lower average requirement for prednisone, fewer patients required immunosuppression with azathioprine, fewer patients were hospitalized for exacerbations. Treatment associated complications did not differ significantly, amazingly, between the patients that got thymectomy and those that were only treated with meds. And then fewer treatment associated symptoms were related to immunosuppressive medications, probably because they use lower doses, I don't know, and just an overall lower distress level related to the symptoms. So, everybody requires kind of a different look. People say it's a snowflake disease, and it is true. There's a lot of snowflakes, and that doesn't mean you're a snowflake like you're not strong. Like the people use the term snowflake. It means you're different than everybody else. So, you have to work with your neurologist and what's best for you, and you have to consider other organ systems, other disease processes, and coming up the right therapy for you. And part of it is also knowing when to pull the trigger on sort of more aggressive therapy, because sometimes you got to sit and wait and see what happens. The disease is autoimmune disease, like other autoimmune diseases. It's going to have fluctuation severity. So you don't want to put people on toxic drugs when you don't need to. So sometimes you got to sit and wait. And that can be frustrating from the patient side. And it's a little, scary from our side too, because we don't want people to go downhill. So it takes a lot of communication back and forth between patients and neurologists. So, send those messages on My Health and let me know, what's working, what isn't. And, we've got to come up with something that works for you. So yeah, it takes a lot of close follow-up. We got to monitor for medication side effects. There are a lot of drugs that can worsen myasthenia, and not everybody knows what those drugs are. And despite our best efforts to educate primary care physicians, and now we have other non-physicians that know even less about some of these drugs. So whenever somebody wants to put you on a new drug, it's probably best to just check with your neurologist or have them check with us. Primarily, there's lists on the myasthenia.org site, but the big ones to worry about are primarily antibiotics. The azithromycin, which is a Z-Pak, has a black box warning on it. This drug can really worsen myasthenia fast, and other drugs in that same class, like erythromycin. And then also ciprofloxacin, the fluoroquinolones, can also worsen myasthenia very quickly, to the point of causing crisis. And again, there's a warning on that label as well. Cipro, we don't give as often, but some people will take it for urinary tract infections. And then, magnesium is not a drug, but it's a supplement that can certainly worsen myasthenia. And, some people take magnesium for cramps. In the hospital, people are replacing magnesium, without thinking about these things, can make myasthenics worse. It can also be found in a lot of tree nuts, especially like cashews and almonds. So, if your myasthenia is under control and you like cashews and almonds, it's probably not going to make much difference. But like if your disease is not under control and you're, for whatever reason, eating handfuls of almonds every night, then you might want to not do that. That could potentially be making it worse. And we need to treat the whole person when it comes to this disease. So what are the pitfalls of treating this? That's Pitfall. I don't remember for your Atari 2600. I had that game when I was a kid. But the steroids given during the acute presentation, I think, is a pitfall. When people are admitted to the hospital and they're in the midst of a crisis and they may be intubated on a ventilator, nobody wants to be in that spot. If you've ever been in that spot, that is, as a patient, that is scary. And when you're given high dose steroids, when you can't move and you can't speak, and there's lights on all the time, you're going to go crazy in the hospital. It makes people anxious and manic, and you can't sleep on high dose steroids. And it also causes a fairly abrupt loss of muscle tissue. So I usually tell the residents at Corewell, do not give them high dose steroids. But there is some debate on that. It may actually help, but just personally, I don't think it's worth it. Over reliance on Mestinon, again, Mestinon is a great adjunct to treating this condition, but if it's if you're taking it 6, 7, 8 times a day or every 2 hours, then it's not. We're not doing it right. We need to treat the disease more aggressively. Ignoring treatment side effects, of these, some people don't tolerate CellCept, they have diarrhea. It's just, we got to try to find something that works better for you. And there are ways around some of these side effects, and that we can still use the drug. So, it just takes a lot of communication.
Dr. Twydell, I also wanted to let you know there's 2 chat questions I'd like to ask you.
Okay.
And we're running out of time, so I don't know if you want to quickly summarize the rest of these pitfalls, because the pitfalls are also very important.
It's all very important. I could probably talk a couple hours about this, but I don't want to.
It's been fantastic, so thank you.
Thank you. Let's answer some questions. Yeah.
Okay, and then we have, all right, so the first question, both these questions came in during the period of time when you were talking about diagnostic tests. So the first question is, how is a myopathy confirmed or diagnosed after GMG has been confirmed?
Oh, okay. So if somebody has myasthenia gravis, and then we think that they may have a myositis as well. Okay. So, well, first of all, in myasthenia gravis, the muscle enzyme testing is typically normal. So if somebody comes in with weakness, and maybe it seems a little strange, or maybe they have a rash, or maybe it doesn't really look entirely like myasthenia gravis, we might check muscle enzymes. And in myositis, most of the time, the muscle enzymes are significantly elevated. So that's one way of at least getting a clue that a myositis is also present. Another, more confirmatory way is by getting a muscle biopsy. Now, we may also do an EMG, because in EMG, we look for certain things that you can see that would not be present in most myasthenics. So it might look like more of a myopathic EMG, which gives us a clue. And then if we really want to confirm it, we will get a muscle biopsy. And there are also some other antibodies that we test for in myositis, so we might test for those as well.
And this is another example of what you're saying. Talk with your doctor. If you're given a treatment plan, something's not going right or continues to not communicate with your doctor. Thank you. And the second question is it possible to have a normal EMG and single fiber and still have myasthenia gravis?
It's possible, but it's highly, highly, highly unlikely. Anything's possible. If I've learned anything in 20 years, anything is possible. And just when you tell somebody, never say never. So anything's possible. I would say that somebody in that condition, if they were triple negative, their myasthenia is probably not very aggressive, and that we might do well with just treating patients, those folks with just mastodon. They're very unlikely to need like high dose immunosuppressive therapy or IVIG. And if somebody's messing around with all that and you don't have any of those things, you know, and you don't feel like you're getting better, you probably want a different opinion, because, you know, while these drugs are amazing and, you know, they do have side effects, they do have consequences. And while we don't see it as much as myasthenia with IVIG, we see it in some other autoimmune conditions. You know, IVIG can cause blood clots and pulmonary embolism. And, you know, it's just, you know, you never want to give somebody that, and you never want to overtreat. So if you feel like you're being overtreated and things aren't getting better, you know, you need to talk to somebody else. Just, you know, there's nothing wrong with asking for another opinion with someone. And maybe that person's me, like, this guy's nuts. Like, but, you know, I'm going to go see Dr. Sakchev and at MSU, but, you know, whatever. Sometimes it's just not a good fit either. So you might not feel you communicate really well with me or somebody else, and you just want a, you know, different opinion. Just let me know. I'm happy to, you know, have you see somebody else who I would trust. And yeah, so yeah, these medications can be dangerous. So it's good to really get you know, have that level of communication with your neurologist.
I'll turn it over to Susan at this point.
Thank you very much, Dr. Twydell. I appreciate you coming on this morning and being our kickoff. That was a great presentation, and definitely appreciate it.